Welcome to Season 2, Episode 8 of the Six Lessons podcast. We are happy to continue this discussion of some of the history and some of the important efforts by certain pioneers in adhesive dentistry. And today we'd like to talk about a pioneer that has been totally forgotten, but I had the opportunity years ago to meet the author of this master's thesis. His name is Stan Wendt. And Stan Wendt, when he was looking at different options to restore the occlusal surface of conservative restorations, was the one who did the best investigations of composite. Most dentists have a bias against composite on the occlusal surface, thinking that ceramics are superior. Well, you have to say in which way do you think they're superior, and you have to talk about the individual characteristics of a ceramic onlay versus a composite onlay, and even more important, a composite overlay versus a ceramic overlay. Some of this information that I'll be talking about has not been published, but it's been discussed, and there is some research, and I have my practice-based research network in my own cases to validate this. And so it could be repeated, but I don't see many people following up on the research of Stan Wendt. But what Stan wanted to know is that if you took composite and you light cured it, it was known that only 60, maybe 65% of the monomers would be polymerized. And if you have more polymerization of the monomers, you get a change in the modulus of elasticity, and theoretically, it should be a change in the wear of the material. But it wasn't that easy. There was a material that was brought onto the market in the 80s that had composite that was highly polymerized through a pressure and a intense light, but mostly pressure and heat, push that 60% polymerization into 80% or even 90%. And the material was called Targus Vectrus. Another material called Concept came to the market. But these materials that were over polymerized had a problem. There was no way to bond the material that didn't have free monomers available in it to polymerize in the next polymerization reaction that would connect the enamel replacement to the dentin replacement. And so this idea of over polymerization or over curing, there's a material called from 3M that is called Lava Ultimate that had the same problem. And once you do that, then your bonds are decreased. Now in ceramic, the bond is not a free radical polymerization connecting the unpolymerized monomers of the intaglial surface with the monomers that are on the tooth surface. And so ceramic has the connection not through the polymerization of the monomers to the intaglial surface, but through a silanization process where the silane connects to the ceramic in an ionic bond, and that ceramic bond can be very strong, but it's not as strong as a cohesive composite bond where you have covalent bonding of composite molecules to composite polymers. Well, these kind of questions, most dentists don't even want to think about what's going on, but if you want to have long-term success, then you need to understand these things. But what Stan Wendt wanted to find out, and he did find out, is in the contact area, if you had a composite onlay to a composite onlay contact, then what would that do long term? And so he was evaluating the wear of these composites, whether they were directly composite polymerized with the light or if they were subjected to heat and added pressure to get a higher polymerization. And they found out that the wear improved a little bit, but again, the downside was the lack of the ability to add composite to a composite surface that was over polymerized. Another important finding was that if you had a composite rubbing against the composite, which is called a two-body wear, then that would wear more than if you had ceramic to ceramic. So a ceramic touching a contact of ceramic has wear resistance that composite does not have. But the ceramic not wearing the ceramic, if the ceramic is against the natural tooth, it can have a wear against the natural tooth, but not much if it's enamel. If you had dentin exposure, it would wear more. And these investigations led to the concepts that Stan, when I talked to him at his home years ago, we talked about some concepts that Gary Unterbrink had introduced into my knowledge. My mentor, Gary Unterbrink, talked about a 2-body wear and a 3-body wear. And what he said, and what I've seen in my own cases, is that if you have a natural tooth on top and a composite overlay on the bottom, then the composite overlay continually is in close contact with the tooth, and that the tooth will wear that composite, and that's called a 2-body contact configuration. Well, if you have ceramic on the bottom, then that 2-body wear actually wears the natural tooth. But how much? A ceramic that's polished or ceramic that is glazed has much less aggressiveness against the natural tooth. Very rarely is it a problem on posterior teeth if we have high polish and glazing. But on interior teeth, what you would see, over my career is that if you had the lingual of a crown in ceramic and it was not polished and not glazed, then the lower incisors would wear, and it would be very noticeable both aesthetically and eventually functionally. Those lower incisors could be shortened significantly. And so the solution to that problem anteriorly was to make a lingual metal in the crown. When veneers came, we were able to completely conserve the lingual of a natural tooth structure. And Pascal Magnier, in his book, made a very significant contribution into prep design of partial ceramic or partial coverage anterior restoration, showing that if you do infringe or encroach on the cingulum, on the lingual of upper incisors, you change the biomechanics of an incisor tooth, and it's a negative situation that increases the flexibility of the tooth. Where if you preserve the cingulum, you have a much stiffer substrate and you have a better functioning restoration. And of course, if you have the cingulum and the lingual of the tooth in enamel, then it doesn't wear lower incisors. In the posterior, how does that work out? Well, it works out also that if you don't polish ceramic and it's against a natural tooth, it will wear it probably around 30 microns per year. If you have composite that's in a 2-body wear continually, the natural tooth will wear the composite about 50 microns. Now, 50 microns over 10 years is a half a millimeter, the thickness of your fingernail. Now, in 10 years, if you lose a height of your fingernail, in 50 years, you've got a little bit of a wear, but the tooth in the natural condition has the ability to have the supporting bone and soft tissue erupt, keep the tooth into occlusion, and you don't have a periodontal condition that in a normal tooth. And so that type of wear on a tooth, the adjustments of the masticatory system are well known, and for most people, it does not become a problem. But in this composite versus composite, if you're losing 50 microns against 50 microns with an overlay against an overlay, then all of a sudden you have what's called a closing of the vertical dimension. Closing the vertical dimension does change the relationship of the head of the condyle to the disc and disc apparatus and the glenoid fossa. And theoretically, it can cause a compression that can cause adhesions that could lead to a clicking and popping and a TMD condition. But these would take decades to happen. Usually, that will happen in a situation where there is hyperfunction from hypermusculature and and sometimes a lot of stress can increase the amount of pressure that we're putting on our masseters and our temporalis muscles. So the whole idea of TMD as it relates to restorative dentistry, to not lose vertical dimension, is an important goal. But again, clinically, it's very rare that that comes up. But in biomimetic dentistry, when I started to do composites exclusively for the first 10 years of my approach with the 6 lessons approach, I would find that if I did overlays, then I would have a flattening of the secondary anatomy. And then that secondary anatomy, it's not as functional, but again, the type of diets we have don't really require sophisticated cusp-fossa relationships. Flat teeth against flat teeth still are able to mash. But usually in a dentition that has not been mutilated, we have 1 or 2 teeth that would have an overlay, and then the rest of the teeth would have cusp-fossa relationship. And so the ability of the brain to capture that envelope of function has not been shown to be impeded. But what Gary Unterbrink told me, and Pascal Magne actually had some clinical research that has not published that validated the things that I've seen over the last 20 years, is that if you save 1 cusp and make an onlay versus an overlay where all the cusps are reduced and then restored, then that 1 tooth or that 1 cusp, its natural dentition, keeps the relationship of the opposing tooth into a 2-body situation that's similar to tooth. And so the wear would be around 10 microns in a year, very small. The onlay with 1 cusp or 2 cusp or 3 cusps preserved, then the onlay that would wear in the first 4 years in this 2-body configuration where it would lose 50 microns, but then at year 4 and 5, that wear would stop if you're preserving 1, 2, or 3 cusps in a onlay preparation versus an overlay preparation where all the cusps were reduced and the composite would be restoring all 4 cusps. And so if you did have a situation when restoring vertical dimension on many teeth was very important in the treatment of a severe TMD patient, then the maintaining the vertical dimension with ceramic obviously is an option. Cusp-fossa relationship for the efficiency of mastication obviously would be improved. And many prosthodontists, that's their go-to idea in occlusal function. But in the occlusal schemes that I believe have been validated around the world, we don't need that many cusp-fossa relationships to program our brain into efficient movement, subconscious movement that's controlled by the cerebellum, not the cortex. But these chewing motions that are in our cerebellum, programmed by the cranial nerves that control our jaw movements, they can be programmed with a simple 3-point contacts, 1 on each side and 1 in the front. Once that's contacting, then the brain says, oh, I have a place that I can reproduce. And the brain is able to get into that position very predictably. We don't need 28 teeth contacting in cusp-fossa relationships in working, non-working, protrusive, all these things that prosthodontists love to talk about and teach in dental school and confuse all the dental students, especially the difference between a denture and a natural dentition. I mean, this is information that a newly graduated dentist would never want to have a test on. But in reality, by understanding how different jaw movements relate to different wear patterns on teeth and different materials can influence those wear patterns and the jaw movements, it leads to some very sophisticated occlusal concepts that we touch on and teach in the 6 lessons, but they've actually been validated by a prosthodontist named Francesca Vailati, who now teaches in Europe. And it just shows that you can get guidance into this maximum intercuspation through cuspids, which is the traditional prosthodontic training, but also through posterior teeth. And I know that John Coyce has also talked about posterior guidance. And these ideas all require a certain knowledge of how a brain works and how a cortex works in programming initial movements, but how those movements can become smoother as they become practiced and put into the cerebellum. But the brain is very smart. It's very able to change movements. And the wear that comes from chewing a million times a year, we have some control. But my solution has always been use composite onlays because they're highly bondable, more bondable than ceramic. And if you're able to preserve one cusp, then you don't have a problem with losing your primary anatomy, and the body of wear stops at about 4 years because now you have what's called three-body wear, which is the opposing tooth, the restoration, but as the restoration has lost a little of its surface depth, then now you have a bolus of food that comes between the tooth and the restoration, and that's the third body that is in this controlling of the wear. So now you just have a layer of food. The tooth don't need to touch to chew and digest food. And so the two-body wear is limited and becomes a three-body wear, and you can have composite onlays that last for decades. We're into our third decade with many of these restorations. But Stam Wendt, as I talked to him about these concepts that I'd learned from my mentor, Gary Unterbrink, he understood those, and he felt like his research validated those, that even if you had a highly polymerized restoration, it would not be anywhere like ceramic as far as contacting a natural tooth and having less wear or a little bit of wear on a natural tooth. So these composites always were the ones that wore. But particularly if you have composite versus composite, that two-body wear of composite, you never have a third body in a contact area unless you have a lot of wear or a fracture, then you get food impaction. But that's not a masticatory function. It's just there. So what was the solution? Well, the solution, if you wanted a person to have tight contacts forever, would be ceramic onlay versus ceramic onlay in the contact area. But as I have my own teeth with composite onlays, and I have my own teeth that actually have some diastemas where there's naturally occurring spaces, and I get food in those spaces often. It doesn't bother me that much, but I'm not that sensitive. Ask my wife. If you have a space between the tooth, you get food. It's a motivation to floss, obviously. But patients, when they come in and say, okay, I've had this restoration, it's been there for 10 years, I'm getting a little bit of food impaction, and I floss it, and it's not a very tight contact. The repair on a composite to composite is so simple. It's just a bulk fill of a 3x3 or a 4x4 preparation interproximally, because you're not having to bond to dentin. You're just bonding composite to composite. And that composite to composite, there's no hierarchy of bondability, so any shrinkage will go to all the walls equally. That composite will change its molecular network a little bit. Basically, you just bulk fill it, put the light on it, just put a thin matrix band, or sometimes I just put a piece of Teflon tape. That's about as thin as you get. And then you bulk fill it, and that tight contact is like, whoo, now the patient can't floss. Well, all dentists have had these situations where contact is too loose, too tight. Some patients like the soft bed, some like the hard bed, and Goldilocks is where the contact is right for most people. But all of these ideas, when we choose the enamel replacement, become very important as long as we understand what the downside of any particular material is and what the benefit is. In my view, the composite onlay always has more benefits than downside. If this two-body wear is a downside, you can monitor that and you can repair it very easily, but you never have a debond. And so I've never had a debond of composite, but I've had doctors that I've trained who are enamored with ceramic for the occlusal enamel replacement. And if they get too thin, particularly after occlusal adjustment, if they're less than 1.5 millimeters, they get to 1 millimeter, then those tend to fracture at 4 years. It can be repaired, obviously, and I've done that mistake, and I've repaired them with composite, and then the composites don't have that problem. But if you have a situation where you'd like a very nice contact to contact that is as much as the two-body wear is as biomimetic as enamel, then the material actually would be gold. If you have a gold onlay or inlay, and the contact is with a gold onlay or inlay, the two-body wear is about 10 microns on each side every year. And then you have a little bit of mesial shift with the natural dentition is part of the normal progression of teeth as they get older. And those long-term gold to gold contacts are about as good as you can get. But gold is a little more expensive. It's a little less aesthetic on the back teeth. Sometimes patients like that. Sometimes patients don't like that. But these conversations that I had with Stam Wendt, and then he gave me a copy of his master's thesis that was published in 1988. 1988 is getting old. We're about 36 years since he had his master's degree. I haven't talked to Stan for a decade. His master's was done at the University of Alabama. But the heat-cured composite resin inlay has the advantage of having a higher polymerization, but that higher polymerization doesn't really cause any problems. But in our technique, we have used a heat modification of the onlay to make the polymerization of the onlay as close to non-shrinking as possible. That usually is a situation where you have an advantage if it's a large inlay, but we do put our onlays or our inlays into a toaster oven. Toaster oven's a very inexpensive piece of dental equipment and costs you $30, $40, but you need to have a candy thermometer to control your temperature, and the ideal temperature is 125 degrees centigrade. That's the same as 250 degrees Fahrenheit. And so 250 degrees Fahrenheit, if you put your onlay into that, that takes that polymerization to the maximum that it will under light curing, which is only that 60%. So you still have 40% of your monomers in islands around the polymers that can be totally polymerized. That situation can be achieved in 7 minutes, whereas your biobase will take about 30 minutes to get to that 90% of its polymerization. And when we say 90% of its polymerization, again, that means 90% of 65% conversion. It's not 90% conversion, but 90% of the 60 to 65% conversion of your biobase will take a 30-minute period. Well, the onlay can get there in 7 minutes if you add heat. So now you have a 95% converted biobase that has 35%, maybe 40% of the monomers. After air abrasion, those 35 or 40% of the monomers are available to get a diffusion of radicals from the cement layer that gets activated with light. And so your biobase has uncured adhesive, and it's into that increased surface area from your air abrasion that we talked about last episode. And so now you have this layer of monomers that is connecting or touching the monomers that have been exposed with air abrasion. And then you have the heated composite layer, and then you have the intaglio surface that again has had increased surface area to expose the 35 to 40% of uncured or unpolymerized monomers in the intaglio surface of your heat-cured onlay. And when you squish that all together, you have the onlay, you have your adhesive, you have the heated composite, you have your adhesive, and then you have your air abraded onlay. Squish those all together, and the light cures all of those levels together. So you have a diffusion of these free radical monomers in the heated composite going to the top towards the onlay. That's called diffusion towards the onlay. And then you have a diffusion towards the biobase, and the light is activating the camphorquinones that are in the mainly your heated composite. And those camphorquinones start the free radicals to go diffusing towards the intaglio surface of your adhesive that's connecting to the air abraded surface of your onlay. And then down you have the free radicals as they grow into oligomers are going into the adhesive. As it polymerizes, it will diffuse into the air abraded adhesive layer of your biobase. and then that will make actual covalent bonds from your biobase to your cement layer to the integular surface of your onlay. And those things are around 40 megapascals. And like I say, we've never had a debond of one of those composite onlays. But the ceramic, if it gets too thin, then the silane starts to get flexed and it does not hold up as well. And you will have debonds with ceramic, where a composite you might get wear, but you will not get a debond of the enamel replacement of your onlay. So we've talked about a few concepts, and obviously this is nerdy stuff for most dentists, but when you talk to somebody like Stan Wendt, then it's important to recognize that science has established these ideas, these concepts, and allows us to now connect a tooth top to bottom, side to side, front to back, so that it acts like a tooth. But the wear on the tooth, that will act a little bit more like composite, but if you have ceramic, it acts more like ceramic, and a tooth is in between the ceramic and the composite. And so we're mimicking the tooth, but we're never getting it right about the same unless you have gold for your onlay, gold for your overlay. Then that two-body wear mimics the tooth better, but the bond is a little weaker to gold, but still you can bond gold onlays to biobases with two materials that we recommend, one from Cuare called alloy primer. You do need air abrasion to have that work, and the other product is from Tokuyama, which is called metal tight. And both of those materials allow a covalent bond to gold to the adhesive to the biobase. And so until next time, get bonded, stay bonded.